Thank you, Benoit, for the introduction. I'm really pleased to be joining you today. As Benoit mentioned, my name is Christina Krause. I'm the Chief Executive Officer with the BC Patient Safety Quality Council. I am joining you today from the traditional unceded territory of the Kamloops Secwepemc people here in Kamloops, British Columbia, Canada.
And my name's Ben Ridout, as Benoit mentioned. I'm the Director of Analytics and Strategic Initiatives at the BC Patient Safety and Quality Council. Get to work with Christina, and am joining you today on the traditional territory of the Kakite First Nation and Coast Salish peoples in what is otherwise known as New Westminster, BC. I'll turn it back over to you, Christina.
Thanks, Ben. We're really pleased to be able to talk to you about a new definition of quality that we have undertaken here in British Columbia. Just before we begin, both Ben and I do not have anything to disclose. But I just wanted to talk to you just first about who we are. We are really an organization that is about advancing improvements in the quality of care and also reflecting on the sustainability of that. British Columbia is a publicly funded health system, and so we are accountable to our Minister of Health. And really our whole purpose is around how we can bring health system stakeholders together to really work towards innovations in care, focused on a patient-family-centered approach to care to achieve that ultimate goal around advancing quality. We work across our entire healthcare system. So as a publicly funded system, we do work across all areas of care, from prevention, promotion, into primary community care, acute care, end-of-life care. And we really determine our priorities around what is needed in the healthcare system. And all of our work is defined around advancing quality. And that's what we're here to talk to you about today, is how do we define quality within what we call our BC Health Quality Matrix. And we also know that patient and family-centered care is really at the core of what we do. And we do run something called the Patient Voices Network, which is a group of patient partners who really have come together, and we support to be engaged in the health system, whether it's around improvement projects, around system redesign. We do now have patients at the table, and our organization helps to foster that. So why define quality? Here in British Columbia, we have had a health quality matrix for a number of years, since 2009. And that original definition was built on work that had been done in some other provinces, as well as the OECD definition, the Institute of Medicine definition. But more recently, we started to reflect around our history here in British Columbia, and also around what the evidence was starting to say. So we know that there are definitions of quality that have been around for some time. And essentially, a definition outlines a number of dimensions that make up what quality is. So the Institute of Medicine and OECD, you can see really strong connection around their definitions and alignment to the dimensions that exist. It is about safety, it's about effectiveness, patient-centered care, timeliness or accessibility, efficiency, and equity. But when you start to dive into those definitions, we started to really think about whether or not they were reflecting what we believed quality to be. And so we reflected on two aspects. We looked at the latest evidence around what we knew was driving quality of care, but we also have been going through a period of reconciliation here in our country around honoring the history and teachings of Indigenous people. Here in Canada, we, many of us, the majority of the population are settlers on the traditional lands of Indigenous people. And when settlers showed up here in our country, we did not treat Indigenous people with respect. We did not seek to understand the learning and teachings. Instead, we brought our own perspectives and put them on to Indigenous people who were here for thousands of years before before we showed up. And what has been happening here is just a reflection and understanding that we have much to learn from Indigenous people to honor what they have to teach us and the history of the land that we have here. And so we actually sought a process to work in partnership with Indigenous people here in British Columbia to reflect on how the history and teachings could be incorporated to how we define quality. And what was really interesting for us is as we did that process and as we looked at the evidence in the literature, they were actually in alignment. And so we worked together to redefine quality. And that's what we wanted to talk to you about today, is to let you know how we have evolved each of those dimensions of quality, and then to give you some examples of how we're applying it within our own health system. So this is a visual view of our definition, and I will walk you through each of these perspectives. Our definition really has encompassed looking at health and wellness at the core. We have areas of care that we will walk you through, and then we have a number of dimensions. We do have 7 dimensions that make up our definition of quality. So a key change here was that most definitions of quality focus on health and a narrower view of health. And what we have really reflected on here is that it has to be both health and wellness, and that we have to really look at that prevention side of things. It is not merely the absence of disease, but when we're thinking about quality, is it around that health and wellness aspect, and that we also need to be looking at how we exist in the system and look at the relational nature of care. Everything that we have exists in relationship with other things, whether it's with other people, whether it's the land that we are on, the environments that we are in. So as we explore quality now here, we are thinking about those relational aspects of the care and the interrelationship. So we are trying to embrace what I would say is the complexity that exists rather than trying to segment things out. We know, for example, that different dimensions of quality are related to one another as well. And so we're not just seeing them in isolation, which really comes from an Indigenous view around relationship and interrelationship. An Indigenous teaching would say that you could not understand a plant in terms of its segmented parts, like the leaves and the stems and its roots, and understand them as distinct parts of a plant, which is, I think, more of a Western view of a plant. But what Indigenous people will do is look at the plant, but what is near that plant? What is the soil? Is there a creek nearby? What are the other plants that exist near it? So we're trying to embrace that as we look at quality and health, is that contextual environment and the relationships that exist within it. And that is at the core of what we are doing here. So just going on, we really wanted to dive deep into the 7 dimensions of quality, because that is where we had the most changes within that. So what I'm going to do is walk you through each of these. 5 of the dimensions reflect the individual perspective and experience with care in the system, and then we have 2 system view lens, the equity and the efficiency components. So I'm going to start with respect. Many of you will have seen this dimension perhaps being called acceptability, perhaps being called patient-centered care. And what we really moved towards was this concept of respect, which is around honoring a person's choices, needs, and values. And we really reflected on respect as a core quality dimension, reflecting the dignity of a care experience, and recognizing that there are power imbalances between providers and those who are receiving care and their family members. And so respect is about being responsive to and making decisions in partnership. So it is that co-creation, and that is in partnership with a person, a family, a caregiver, or in other instances, a community. We used to, in British Columbia, call this dimension acceptability. And the reflection and feedback that we were looking at this was that acceptability denotes sort of a good enough perspective, rather than moving towards appreciation, respect, and choice. Safety was the next dimension, and many of you will know this as the dimension which is the absence of preventable harm. So what we did is we reflected a new definition to talk about avoiding harm, but also fostering security. We also recognized that safety goes beyond just the physical safety, but it includes cultural and psychological aspects. We know that cultural safety is a big driver of care outcomes for our Indigenous people here in British Columbia. This is around how safe people feel to receive care within their own cultural practices and choices. It's very strongly related to respect. We also know from the literature that psychological safety, the ability to speak up when you feel there's something potentially going wrong in your care, is a huge driver of safety outcomes as well. And there is a lot of evidence now linking psychological safety to clinical outcomes. So safety is the extent to which services prevent or minimize harm that could unintentionally result from the delivery of care, but also to the extent to which they promote trust. And that is getting into that fostering security aspect. So we can have clinical harm. These are the adverse events that we know, that we often hear about, and surgical site infections, preventable deaths, medical complications. But we also know that care providers, staff may experience injury themselves, or burnout, or vicarious trauma, and that emotional, psychological, and spiritual harm can be inflicted by limiting a person's autonomy or subjecting them to discrimination. So there are many aspects of safety, and so we have an expanded definition of safety for us that we are now aspiring to, that ensures not only physical safety, but cultural and psychological safety as well. And this really is, I think, one of the big fundamental shifts that we've had that is came from our Indigenous partners, but also bore through in the evidence around what drives quality. The next dimension is accessibility, and this is a long-standing definition. Access is often the one that our politicians spend a lot of time on, which is really, the ease at which health and wellness services are reached. So we know wait times is a big target in advancing quality. So it's really the extent to which people can receive care where and when they need it. But the aspect that we have added to this is, the recognition that in order to access services, there are physical, financial, cultural, and psychological barriers to receiving information and care. And that it includes what we have termed a welcoming entry to receive the care, but it also extends to the transitions between and within services. So traditionally, access has been about the initial access point into the system, but we've recognized that access only works when we have effective transitions in care. And we do know that when transitions in care do not work well, we have big quality issues. And we also know on the cultural and psychological barriers to receiving care can actually limit people's access. So if people do not feel safe or welcome into a facility, into a care site, they will not come. And we have examples of this here in our own province where people have experienced racism when receiving care, and they do not feel safe to go back and receive that. So this welcoming entry has been a big part that we've been reflecting on. And this is an example of a facility here on Vancouver Island where they've worked in close partnership with the community to reflect and to honor the cultural traditions and practices so that people feel welcome and connected to the care, to the location where they're going to receive care. So this is outside of one of our emergency departments, which has taken a long time and building trust with the community to get to this place. The next definition that we have is appropriateness. And this is about care that is specific to a person's and or a community's context. So again, we've reflected that care can be received by a community or an individual. And we know that appropriate care is informed by evidence and best practice to optimize care to achieve a specific person's health and wellness goals. And it's about weighing the risks and benefits of interventions to prevent the overuse or underuse of treatments and services. One of the key changes that we did here was to acknowledge what constitutes evidence. So we know that, randomized controlled trials are often the gold standard, but we've also expanded our definition to include what we call experiential evidence. So a lot of the traditional Indigenous practices include what we call oral history or teachings, and these are passed on through story and shared experiences. And so we are wanting to value that as evidence as much as we do the more traditional forms. And so how do we bring that in to the care process? The care process goes beyond the clinical aspect of perhaps administering a certain medication or some sort of procedure. It is about the whole person care, right? So at the core, the health and wellness aspect is about the emotional, psychological, social well-being of an individual in addition to their physical aspect. Our next dimension is effectiveness, and this is care that is known to achieve the intended outcomes. Again, it is informed by evidence, but it really is about demonstrating continuous study around the results of care, as well as looking at promising new methods to improve health and wellness for all. The next two dimensions reflect what we call the system perspective. And, equity, as we've been reflecting, as we've all gone through this global pandemic, equity was one of the dimensions that really rose to the top. And I think the pandemic really showed equity as a strong driver of outcomes. And we, I think, have a huge opportunity in the world to look at one of the key learnings from the pandemics is that fundamental need to address equity. Equity is being the fair distribution of services and benefits according to population need. And it's really about understanding the people served, focusing on the social determinants of health. And a key aspect that we built into our definition of equity was around overcoming structural barriers and eliminating systemic oppression to address gaps in experience and outcome. We recently had a review here in our province around Indigenous racism, and it found significant gaps in care as a consequence of racism. And we know that equity is a big driver of that. So when we have equity, every individual has an opportunity to achieve their health and wellness goals. So their own individual goals, regardless of the social, economic, or geographic location. It doesn't mean that everybody has the exact same care, because we know that each person has a different circumstance. It is often driven by where they live, but also their own history and their needs. The last dimension is efficiency, and this is really about the optimal and sustainable use of resources to yield maximum value. Here in Canada, healthcare being a publicly funded system, we think a lot about sustainability in our system, and so we did build in the value and the concept around sustainability into our definition, because without that, we won't be able to be efficient. So the commitment to efficiency is demonstrated by the thoughtful use of financial, but also the environmental resources and our human resources to deliver the health and wellness services of today and into the future. And it's about maximizing that capacity of the people, the resources that we pull on in the environment. There's a lot of work now reflecting around the impact that the health system has on climate change. So we're thinking about that as part of our efficiency definition going forward, so that we reduce and minimize waste and reflect on, are we using unnecessary energy, materials, and money? So it is going beyond the money equation. We also, within our matrix, and Ben is going to be showing you a practical example of how we use this as a tool around improvement projects, around health system planning or evaluation. And so we wanted to reflect what we also call the areas of care within our system. And So it begins with the early years, and we've learned a lot from Scotland and many others around the importance of early years. We know that the adverse childhood events have a huge impact onto adulthood. So we are thinking a lot about how do we optimize the early years? How do we look at early development and maternal health and wellness as a strategic focus within our system? And then we also focus on what we call strengthening health and wellness, which is around promoting well-being and preventing injury, illness, and disability. We also know that a core area of care within our health system is that return to health and wellness following an acute illness or injury. And so that is our hospital-based services and how we can actually move people to that pre-illness or injury state. We know that many will live with illness and disability, and so that's whether it's chronic illness and or disability, and how are we providing care in that area. And then what we now are framing, which used to be called end of life, we've reframed it to coping with the transition from life. And part of that is the recognition that different individuals have their own belief systems around what happens when your life ends. And that transition looks different for everyone. And so we've reframed it to try to be more inclusive around that, but recognizing that the planning and care and support for life-limiting illness and bereavement is an important part of our health system. So I'm now going to hand it over to Ben, who's going to walk us through some different examples of how we use our health quality matrix.
Thank you, Christina. As Christina mentioned, we not only wanted to share the updated definition of quality that we've developed here in British Columbia, but recognizing that we can have a perfect definition, but if no one's using it and it's not driving improvements in care, then we really haven't achieved the vision of our organization. So what we wanted to spend the second half around was really diving into the use of the matrix, talking about some of the common ways that it's used in the health system and providing some examples that might trigger some ideas for your own work. So the most common uses of the matrix fall within one of these four categories that we have on the screen, whether it's for planning purposes, improvement, measurement, or evaluation. While we can talk about these each separately, in reality, there's often a lot of overlap, and so they may not look like distinct categories within your work. When we talk about planning, this could be at the more specific level in terms of planning for an improvement project, or we also see the matrix being used at a broader level, whether it's for program planning or strategic system planning. Within improvement, we often find that the matrix is a useful tool to help in establishing an improvement project when you're getting started. So it's very useful at the beginning when you're looking to establish the scope and boundaries, looking through the matrix to identify which areas of care the project will be focusing on, as well as which dimensions will be targeted, whether it's all of them or a few of them. It's also helpful to think of the matrix throughout the life cycle of an improvement project, and probably helpful to use an example for that, which I'll get to in a second to show how we've used the matrix in BC throughout an improvement project. In addition to those two categories, we also have in terms of measurement. So we can use the matrix to help guide our quality measure development, ensure that we have a balanced set of measures, and when we're developing a measurement plan within an improvement project. And finally, similar to measurement, we also have the use of the matrix within evaluation, where we're looking at evaluating our impact. Have we really made changes within the areas that we targeted? So to assist with improving the matrix in our resource, the BC Health Quality Matrix, we have this practical tool that is a way to help the end users really apply the matrix within their work. So the format is intentional to prompt users to really have a glance and consider the multiple dimensions and areas of care thoughtfully and methodically. And it's laid out in a way where you can plot out where your project program is touching the multiple dimensions or areas of care. So we can see the 7 dimensions of quality that Christina walked through along the top, forming the columns, and the 5 areas of care along the left-hand side, forming the rows. It's a little bit difficult to see on the screen, but when you see the actual tool, you'll notice that there are dotted or dashed lines between each of the columns and rows. This is also intentional to recognize that, well, we have 7 distinct dimensions and 5 areas of care. There's also interconnections between them, and we recognize that depending on your setting or your work, you may want to adjust or adapt this tool to have multiple areas of care combined together. So the dashed lines really indicate the ability for the end user to customize to their context or setting. Well, it's all good to talk about. Like I said, probably easier to walk through an example to show how the matrix has been used in some work here in British Columbia. At the council, we had used the matrix within our CLEAR initiative in a few different ways, as I mentioned, to be able to show how it can be used throughout the life cycle of an improvement project. So CLEAR is an improvement initiative aimed at supporting teams from long-term care homes to address the behavioral and psychological symptoms of dementia. The initiative aim was targeted around reducing the potentially inappropriate use of antipsychotics. However, the impetus for the CLEAR initiative originally came from an interest in looking at addressing dignity for seniors in BC. Now, dignity is a broad topic, and so in order to narrow down to a specific improvement initiative, we were able to use the matrix to walk through the multiple dimensions and look at what within dignity was really the pressing need and where could we focus. And so by using the matrix, walking through and thinking about the 7 dimensions of quality, we're able to establish the focus, at least as a start, on potentially inappropriate use of antipsychotics as a way of getting at dignity for seniors in BC. We also use the matrix once we'd established that focus for the project in terms of laying out our plan. So mapping out the initiative across the 7 dimensions of quality to ensure that while the focus may be within the aim on appropriateness, we recognize that we're also touching multiple dimensions. And so we're able to use the matrix to look at which dimensions and areas of care would be focused on within the initiative. Now, when I mentioned that we can use the matrix throughout the life cycle of a project, we then also utilize the matrix as we got into running the CLEAR initiative. And so we developed a driver diagram, which essentially can help tie a number of change ideas to your overall project aim. And we used the matrix to be able to map out those change ideas to ensure that we had identified change ideas across the various dimensions of quality that we'd identified would be worked on within the initiative to ensure that we didn't have any gaps, that we'd identified all the areas that we wanted to focus on. In addition, we also use the matrix when we're developing the measurement plan. So again, this is where there's some overlap between the improvement category measurement. So within CLEAR, we established a measurement plan that had a balanced set of measures. So based on the aim, we had an overall outcome measure around the percent of potentially inappropriate antipsychotic use. So looking again at the appropriateness dimension. But we had a number of measures within the improvement project that the long-term care teams could track. We looked at the number of falls, so within the safety dimension, the percent of care teams that were expanded to include patients and families, looking at the respect dimension, the percent of medication reviews that were completed, again, looking at safety, also the number of residents on non-pharmacological interventions, looking at effectiveness as well as respect. And then finally, when it came time to evaluate the CLEAR initiative, as we ran 3 waves here within British Columbia, we're able to again utilize the matrix to map out the various areas to evaluate against and ensure that we had impacted the dimensions that we had targeted. So that's one broad example of improvement initiative here in BC and how we sort of touched on almost all 4 of those categories in using the matrix within it. Another more specific example is around looking at how we can utilize the matrix in developing quality measures. There's an example in our companion guide for the matrix, which I'll talk about briefly in a second, around looking at developing quality measures for an inpatient stroke rehabilitation program. And you can see here that the team has mapped out a number of quality measures across all 7 dimensions of quality and specifically targeted within one area of care, so returning to health and wellness, as that's where they work and focus. This team has identified, as I mentioned, quality measures across all 7 dimensions of quality. We recognize that may not always be appropriate to the work. In other cases, you may be identifying measures within 3 dimensions of quality if that's where sort of the focus is. But the matrix then ensures that we can have the conversations and are aware of the other dimensions of quality, so that we can at least consider ensuring that we're not having unintended consequences as we work within a complex system. So that's an example of developing quality measures at sort of a program level. We also know here in BC, our Ministry of Health at the government has used the matrix to map out a health performance system scorecard, and again, ensuring that we have performance quality measures across all the dimensions of quality that they're looking at and tracking to assess health system performance. So those are a couple of examples. Recognize that it's often helpful to have even more. So one of the tools that we've created to complement the BC Health Quality Matrix is our companion guide, which provides additional case studies, goes into more detailed examples, and it also provides some key questions for the end users that they can use with their team to really prompt some thoughtful discussion around whether it's the health and wellness section that Christina touched on, the dimensions of quality, helping to identify where the focus might be for the work or setting, as well as looking at the areas of care. So this companion guide is available on the BC Patient Safety and Quality Council site, and we've included a link here on the slides that you can use. We've also here in BC, again, recognizing that it's good to have our updated definition of quality, but we want to ensure that it's being used and adopted. We've done a 1-hour lunch and learn looking at the practical application of the health quality matrix within the BC health system. So we have a link to the recording from our quality cafe. And we also run a quality learning series, a 3-week series with health professionals who are working on a project that they can bring in, and over those 3 weeks, take a more detailed dive into the matrix. And it's actually more of a, how do we apply and use the matrix within those specific projects? So a very focused look at the matrix and sort of taking it to that next level of application. So we've included links to each of those within the slides that will be available. With that, we do want to ensure that we protect some time for questions and that we can have some discussion about this, and you're not just listening to Christina and I for the entire session. So I will pause here. I'll just point out that we've included our contact information on the slide if anyone would like to follow up or learn more information about the BC Health Quality Matrix. And with that, I'll turn it back over to Benoit so that we can get to some of the questions that are coming through. Thank you very much.